Imagine this. You're a normal 20, 18 something year old. You're going to soccer practice, you're going on dates, and you have the urgency to run to the bathroom all of a sudden. You run in there, and the toilet is just, scary. Looks like a horror movie. And this is the reality every day for people that suffer from inflammatory bowel disease. This is a very unique patient population in that they're very young, they're very scared, and they're very sick. And as gastroenterologists, this is one of the main conditions that we deal with, leading these people through a lifelong, sometimes life threatening condition.
You cannot supplement your way to health, but there are things that we need to add to our lives that can maximize our pathway to wellness. The American diet is virtually devoid of omega-3 fatty acids, which play a major role in cardiovascular disease, gut permeability, and mental health. Personally, I take omega-3s every night, and Irb is the best place for clean, natural sources of supplements. I love the ZenWise omega-3 fatty acid supplement, which is free of fish burps and good for the environment. Head on over to maximalbeing.com/IHERB, that's IHERB, and enter the code B as in boy, D as in dog, B as in boy, 5528, and receive 10% off your orders for all supplements. Maximize your supplements with IHERB.
Welcome to Maximal Being, a GI doc and ICU nurse that break down the science so you can exceed your gut health, nutrition, and fitness goals. So, let's smash the bro science and optimizing your health with your hosts, Doc Mock and RN Graham.
And so, as always, I'm Doc Mock. I'm a therapeutic endoscopist. I'm also a functional medicine practitioner here in Cleveland, Ohio. And joining me today is Jackie P.
Hello, everyone. It is I, Jackie P., your layman. I'm not an expert in anything we're going to talk about today, so I will be here to make sure that all these brainiacs keep the conversation jargon-free and easily to understand. And I'll pass it to you, Dr. Case.
Hi there, everyone. My name is Dr. Case. Thank you for that introduction. Like you mentioned, I'm from Michigan. A little bit about my background. I did my internal medicine training at UIC in Chicago, followed by a fellowship in GI and hepatology at Scripps in La Jolla, California. And lastly, an advanced fellowship training at the University of Michigan under the mentorship of Dr. Maria Abreu.
Hi, I'm Dr.
Nice.
Mo Naem. I'm also a gastroenterologist here in Cleveland, Ohio. I did my internal medicine training at University Hospital's Case Medical Center here in Cleveland. I am also from Michigan originally, but I did my GI fellowship at The Ohio State, where I did do a specialized year in inflammatory bowel disease. It's a pleasure to be here today and look forward to a very interesting and fruitful conversation.
Yeah, I'm really excited as well. This is one of the topics that, as every GI doc, as everybody that is interested in gut health, this is at the forefront of everybody's minds. And so GI, we have a relative alphabet soup of diseases and terminologies. And so, Dr. Case, I wanted to know if you could just tell our listeners, what is IBD, the types, and how is it different than IBS?
Absolutely. That's a great way to start off things. We get so many patients that come in saying, I have IBD or I have IBS, and they don't really know the difference. So the most simplest way that I explain it to patients is IBD is most likely an autoimmune driven phenomenon. There's a lot of other factors that we'll go into that can contribute to that, but specifically comes in two flavors. It comes in ulcerative colitis and Crohn's disease. Ulcerative colitis primarily impacts the colon, while Crohn's disease, unfortunately, can impact any part of your GI tract. That means from your mouth all the way down to your rectum. With regards to IBS, this also comes in different flavors as well, but it's called irritable bowel syndrome. And that can be present as diarrhea, constipation, or a mixed format of the constipation diarrhea. Aside from that, I try to explain to patients that both of these entities, IBS and IBD, are treated very, very differently. But interestingly, a patient with IBD, an inflammatory bowel disease, can have overlapping IBS, which can make things a little bit tricky. What's a real flare from IBD and what's IBS? IBD can increase your mortality, while IBS is literally a pain in the butt, literally and figuratively, but doesn't increase your mortality, if you will.
That was an excellent summary, and thank you very much for that. You know, I think a lot of the listeners are going to wonder. I know every time I tell a patient that they have one of these conditions, Crohn's or ulcerative colitis, they want to know how they got it. And so, Dr. Naem, can I get it from COVID? Can I get it from hugging somebody with COVID or that's sick or sniffly? How do we get inflammatory bowel disease?
Well, if we knew exactly how we got it, or at least if I knew that, I think I'd be a very, very rich man, because I would be able to find a cure. Unfortunately, there's no real trigger as far as we know, but there's a lot of factors that contribute to people getting inflammatory bowel disease. We know there's a very strong genetic component. We used to think it was disease that mostly affected people of Ashkenazi Jewish background, but we've realized it can actually impact anyone of any race, sex. It's a very unbiased disease. We do know there's some environmental factors, there's some dietary factors, which I hope we're going to get into today, but there's really no clear trigger. There is some truth that maybe an infection can trigger this. Sometimes having a bacterial or gut infection can be the initial impetus that actually causes a disease to flare. Whether or not COVID can give you IBD, I mean, that's something that still needs to be looked into. But as far as we can tell, there's no clear trigger. Hugging somebody definitely is not a trigger to get inflammatory bowel disease. But again, it's something that we're still looking into as to the exact cause in certain patients. We do have some theories. There's the equator theory. This was actually seen in patients with multiple sclerosis, which is another autoimmune disease. And it was shown that if you take somebody like myself, who's from North African or Egyptian background, and you were to move me to somewhere further away from the equator, like Michigan, where I'm originally from, you actually increase my risk of getting autoimmune disease like multiple sclerosis or even inflammatory bowel disease. Whether that's linked to nutritional deficiencies like vitamin D, because we get a lot less sun here in Ohio, Michigan, and Midwest, that's definitely possible. Is it linked to a Western diet? That's something that's been shown over and over again. Western diets that are high in red meats, low in dietary fiber, can that be a trigger to inflammatory bowel disease? And we're hoping today that Dr. Susan Kais will help break that down for us and explain it to us. And I think it's a good segue to today's talk.
Yeah, thank you so much for summarizing that. And we're gonna start off the topic as far as the impact of different dietary factors on IBD. I'm gonna turn it over to my co-host here, Jackie P.
Thank you, Doc Mock. Sorry for that. So, I mean, IBD, IBS, right? All these affect the GI tract in multiple different ways. So, I mean, I guess we could start with you, Dr. Case. What would you say are the impacts of our diet, right? Especially here in the West, you say it's impacting a lot of younger folks, right? What is it, how we eat now that is increasing, that you're seeing, increasing these triggers for folks who might be suffering from IBD, and how, it can make it worse or better?
Yeah, so basically, our westernized diet, unfortunately, is really not a very good diet, as we know. It includes a lot of processed foods, and these processed foods have a lot of preservatives. And some of these preservatives, we do know in animal studies, increases inflammation, one of those being carrageenan. Also high fructose corn syrup can contribute, but there are many others. So there are different types of diets that IBD patients, they go online, they do some research, that they come in and ask about, those being the specific carbohydrate diet, the IBD anti-inflammatory diet. Patients inquire about gluten-free diet, the low FODMAP diet, paleo diet, and what other diet they may find on the internet. So it's important for clinicians, doctors like myself, to be aware of what patients are trying to do at home and trying to help direct them in a way that may help ease their symptoms, identify a diet that may work better for them, clarify some myths for them that they've read on the internet. Unfortunately, there's not a lot of robust data in human models, but there is a good amount of animal studies out there to help give us some idea of what would be the best approach.
So I was just going to say, just talking macronutrition. So before we dive into each individual diet, Dr. Naem, what do you think is the ideal carbohydrate for somebody with IBD to have? Do carbohydrate composures, glycemic indices, et cetera, did those things impact IBD, both in terms of making it appear for the first time or in terms of how somebody's going to do over time?
Yeah, we definitely know that there's a link between complex carbohydrates and IBD. And we also kind of want to even break that down to our IBD patients in terms of what kind of carbohydrates and foods they should be eating during a flare, which is when they have active disease, or during a time what's called remission or symptom-free disease. We do know that, again, complex carbohydrates that could be found in like leafy vegetables or non-leafy vegetables as well. Certain fruits and things like that are high in what called FODMAPs. Those are kind of more of complex carbohydrates. So things like wheat and gluten, stuff like that. We know that can definitely be an impetus or a trigger to cause active disease or a flare. And conversely, simple carbohydrates or simple sugars are things that are found, like glucose or sucrose, that are found naturally in fruits. Those are definitely less inflammatory. We also kind of know from a macro aspect too, again, like I alluded to earlier about red meats. We know that red meats, for instance, inhibit hydrogen sulfide production in the colonocytes, which decreases the formation of what's called butyrate, or these short chain fatty acids that help bathe our colon cells and keep them healthy. So we know that a diet like the Mediterranean diet, which is kind of more of a global type diet, we know can decrease inflammation because it's low in red meats, high in things like fish and chicken, also very high in fiber as well. And again, we have to kind of differentiate to our patients what to eat during a flare, or again, symptom disease, active disease, or during a remission state when they're not active.
Yeah, that's very interesting. You bring up the Mediterranean diet, which I feel like seems like the superhero that we need in a lot of health issues, right? GI tract and your heart and just overall health. Can you speak a little bit more about, you spoke about inflammatory, right? And we know from past episodes, right? Omega-3 is, it should be a superhero. I don't know why folks aren't talking about it more. But can you talk about a little bit about, how that helps, is that something that, okay, if I'm in a flare up, right, with IBD, is it something that I should be having more of during a flare up? Or is it something that helps maybe limit the frequency and intensity of flare ups? So can you speak a little bit?
Yes, that's actually that's a great question, and I hope that Dr. Susan Kais will come in to assist me on this one as well, because she's a dietary expert. But we do know that there's something called omega-6 and omega-3s. Omega-6 are pro-inflammatory, and those are found in animal fats, specifically like meat, red meat, and any kind of fat that turns hard when left to sit at room temperature. Omega-3s are actually anti-inflammatory. So yes, I would definitely recommend for our patients to do things rich in omega-3 fatty acids, like certain fish and whatnot, because those are actually anti-inflammatory. So yes, it's definitely something we want to discuss. And the Mediterranean diet has kind of become the superhero in the IBD world, also with for a good cardiovascular diet, decreasing the risk of heart disease, neurological disease. It really is a very rich diet. And I joke with Dr. Mock about this before. is that on the Mediterranean diet, wine is on that list of good foods. Now, mind you, wine in moderation, 1 to 2 glasses a day may be helpful, but in certain inflammatory diseases, excess alcohol can be pro-inflammatory. So again, everything in moderation is likely okay.
Yeah, it's an interesting balance with the alcohol paradigm, because too much alcohol will cause leaky gut, right? It pokes little holes inside of your intestinal tract and gets
Absolutely.
your bacteria, through into your bloodstream. So that's definitely pro-inflammatory. But resveratrol, which is present in only red wine, right? And that is a antioxidant. And so, for people with IBD, if you do have intolerances to either sulfa compounds, which can cause a histamine reaction in red wines, or have difficulty sleeping, or have some degree of leaky gut or irritable bowel on top of your IBD, maybe taking it in a supplement form may be a better route. Dr. Case, what are your thoughts on protein? So we mentioned a little bit about animal protein kind of being pro-inflammatory to the colonocytes, not helping with butyrate, but is all protein bad for your GI tract and for IBD?
I think anything in excess can be bad for you. There are studies out there looking specifically at high protein diets, looking at red meats for animals versus protein-based, plant-based proteins rather. And those taking in a high protein diet consisting of a lot of red meats can actually increase inflammation versus one of protein, a plant-based protein. I try to, whenever I'm speaking on the subject matter, it's so complex, I try to simplify things for my patients and just keep it nice and clean and easy. The question with regards to should I be taking omega-3s and omega-3s during a time of inflammation, I think you should be taking it all the time. I think that will help limit the potential of going into a flare, but it's not just one thing that's driving this inflammation. It's the overall, an individual's overall dietary habits. So it's putting into place a number of these things that hopefully we'll be talking about that will improve an individual's lifestyle, their symptoms, and lessen the risk for inflammation and flares, basically, and their quality of life overall.
Okay, yeah, and that makes a lot of sense, right? Omega-3s are important for a lot of things, so you should be taking it regularly. So let's talk about something else, right? Along with omega-3, right? Glutamine, Dr. Case. What would you say? Like, what is the role of glutamine in IBD? Take it away.
For me, I'm not very well versed on glutamine in my practice. Haven't really put it into play. So I don't know if Mo has put it into play in his practice at all with his patients.
I think what you're trying to get with this is, so we had talked earlier about the colonocytes using short chain fatty acids like butyrate, things like that, which is the main nutrient source in the colon, which that comes from basically the stool that's sitting in the colon and the bacteria breaking it down, causing those short chain fatty acids, which help bathe the colon cells and make them healthy. Now, in the small intestine, glutamine or glutamate is the main nutrient in the small bowel. Now, I personally, to be honest, have not read any studies about giving glutamine supplements to these patients. However, in the pediatric population, there are studies showing what's called the elemental diet, which is shown to even produce about 85% remission in some Crohn's patients in the pediatric population. And I believe that is one of the main nutrients in the elemental diet that they give to these patients to help basically put them into remission and taking away any of the complex carbohydrates and proteins. I believe that's what you're kind of going with that question. Yeah. But personally, in my practice, it's very difficult from a micronutrient level like that to kind of prohibit diet when, especially during a flare, you want your patients on a high protein, high calorie diet because they need that to kind of help them get into remission.
We talked a little bit about FODMAPs. So, and we briefly touched on like some of the food groups that have FODMAPs in them. But Dr. Case, what are FODMAPs, and what sort of foods do FODMAPs live in?
Well, FODMAPs, we primarily talk about FODMAP diet in patients with IBS. But like I said earlier, there can be overlapping. Patient can have IBD with overlapping IBS. Now, I always mess up the FODMAP acronym. So it's fermentable oligosaccharides, disaccharides, monosaccharides, and polys diet. So, and then I also believe it's a misnomer. It's really not a diet per se. It's kind of a roadmap to give patients who have IBS and a way to figure out what component in their diet is contributing to their symptoms. If it is a dietary stimulant, if diet is a stimulant for their IBS or their IBD for that matter. I really don't push the FODMAP diet in my IBD population. I lean more towards the specific carbohydrate diet as well as the IBD anti-inflammatory diet, because those are the diets that, from my studies and from what I've seen reading the literature, these diets not only improve your quality of life, but can possibly change the natural progression of your disease. While the FODMAP diet in itself just improves things clinically, symptomatically.
That's a really great definition. And it's funny because the FODMAP diet was created at the University of Michigan. That's well, more Michigan's claim to fame.
It still has it still has its usefulness in the right patient.
It does. And, I agree 100% with what Dr. Suke said. I use that diet mostly when I'm treating a secondary component of irritable bowel syndrome in my patients. And it's still a great diet to follow. And again, it is a misnomer. It's not technically a diet. It's more of a roadmap. And I tell my patients, you don't have to eliminate these foods, but definitely cut down or avoid these foods. And certain foods that are high in FODMAPs that you wouldn't be aware of, for instance, things like apples, honey, agave, which you think is really healthy because it's a low glycemic index source of sweetener. So these things are things that I tell them to avoid. However, things that I do tell them to eliminate are any artificial sweeteners, which is on the high FODMAP diet. So anything that ends in OL at the end, xylitol, sorbitol, anything like mannitol, anything that ends like that, and you see it on your pack of gum or your mints, those are things you definitely want to avoid because they're definitely not very nice to the intestine. And it's very harsh on the intestinal bacteria that you want to make sure you're providing a healthy kind of environment and nutrients for those bacteria. So I mirror exactly what Dr. Case said, and I do basically what she does.
Yeah, I can't agree with you more as well, Mo. Like for me, for my patients with IBS, I find that the FODMAP diet, which is not a diet again, it's a roadmap. Unfortunately, as clinicians, we don't have time to sit down and break down every aspect and how to do it. I used to just give my patients a handout and then tell them, come back and see me in 3 months. Let me know how you're doing. Did we have any results? Did we find a culprit in your diet? Like Mo said, there can actually be good things that you're eating that are good for you that can trigger your IBS, and you would not be aware of unless you were familiar with them. And then they've come back and say, you know what, I read the handout. I had no idea where to start. So with that being said, I started sending my patients to a nutritionist. Unfortunately, there's not just one nutritionist I can go to. I'm in a private practice. Payers don't pay for the same dietitian, nutritionist. So I get a smattering of results, but for the most part, I would say 90% of my patients that I do send to a nutritionist, dietitian for better teaching on how to actually put the diet in place, they are able to successfully identify a culprit or a few culprits and eliminate them from their diet and have symptomatic relief. Now, unfortunately, for the specific carbohydrate diet and the anti-inflammatory, the IBD anti-inflammatory diet, I don't think a lot of nutritionists or dietitians may be putting that into play. So that's for those diets, I put it on myself to take the time and explain what it is, what it entails. And you'll find that a lot of patients, when they're on max aggressive therapy, they don't know what else to do. They're like, doc, what else? Is there something that I'm doing? And that's at the point where you can have a huge impact and say, hey, let's talk about your diet. Tell me, what do you start with your breakfast? What about lunch? What about dinner? So we focus in on their diet during that interaction, and we start making little changes. You can't just throw everything at them, just one little change here, one little change here, and coming back to the office to reassess. And at the end of a culmination of putting one of those two diets into play, you can actually see patients have clinical improvement in their symptoms or quality of life. And actually, we can also monitor these objectively with inflammatory markers, say, hey, not only are you feeling better, your markers of inflammation are coming down. That's awesome.
Yeah, that's kind of exactly how I do it as well in my practice. With the initial diagnosis of inflammatory bowel disease, I think like Schiffer had mentioned at the beginning with his introduction, it's usually a very young person, very healthy, had no medical issues, and all of a sudden we are completely changing their world by telling them that you have a chronic disease. Now, the mainstay of therapy is some kind of anti-inflammatory or medication that's going to decrease suppress your immune system. But I think it's very important for us as GI doctors to make sure that we're treating the disease in a multifaceted approach. So obviously medication being the mainstay of therapy, but also talking about their psychosocial behavior in their life and how that's affecting them. Talking about diet, talking about nutrients, vitamin deficiencies, things like that. And I think that's something that I do as well, Dr. Case, as I go along the disease process with them at the initial visit, then the second and third. And as we move on, we just kind of build up until they're in remission. And once they are hopefully in remission, I really focus on the dietary aspect, the psychosocial aspect, because again, it's very hard for a lot of us in the medical field to do all that in even a 45 to 60-minute setting. If we have that at our disposal, that's still very difficult, and it's a lot of information for some of our patients. Although a lot of our patients now are highly educated, highly motivated, have a lot of resources at hand to research stuff. So it always comes up to be a very great, fruitful conversation between myself and my patients. And definitely everything that Dr. Case said, I agree with as well. Is you have to kind of treat this in a multifaceted approach in terms of how you deal with the disease, not just with medications, but again, talking about their life, talking about their diet, and kind of going through every one of those little aspects and really helping them kind of along the way until they are in what we call remission or disease-free state.
Exactly. I would also add to what most mentioned is that these diets are complex and they can be a lot of information for patients. And we have to acknowledge that and take our time with them and really bring it in at an important point during their disease process, if you will, when they're willing to, because as we know, diet in general is very difficult for people to change. Nobody wants to change their diet. If we change our diet, we would all be healthy, skinny, and we wouldn't have this obesity epidemic, because people refuse to believe a lot of times that their diet is that impactful on a disease process. But as we go on with the studies and the research, it's really the diet driving a lot of this, and building that patient relationship and that trust, like Mo said, bringing patients back in, letting them know they have this chronic autoimmune driven phenomenon, that you're going to be with them throughout the way, and hopefully through therapy, modifications in their diet, maybe psychosocial help as well, that we can get them back to their baseline, that they only remember that they have an inflammatory bowel disease is when they have to take their medication.
Interesting. That's now that we're talking about diet, right? And how much of an impact it can be for a patient suffering from IBD. Can you expand, Dr. Case, on on that particular autoimmune protocol diet, and what that looks like?
So the simplest way to put it is the IBD anti-inflammatory diet looks at certain foods that are pro-inflammatory, that meaning driving inflammation, versus anti-inflammatory that limit inflammation. So if I'm treating you with aggressive therapy, biologics, immune modulators, and you're going out there and having a westernized diet or a standard American diet with the acronym SAD, which it is a very sad diet. I'm fighting a pro-inflammatory state with everything that I'm doing. You're negating possibly the benefits of my medication. So there's tables and charts with different food items that are considered that we know can be pro-inflammatory versus anti-inflammatory that once again were studied in animal models. So to go through all these different ones is a lot, but if you give them that concept of a very simplistic form, they can grasp it and be like, okay, I want to eliminate food products that are going to drive inflammation. These other ones, these ones actually are anti-inflammatory, and I should start consuming these more on a regular basis to decrease that inflammation in my system. That makes sense to patients. A lot of times, I don't know if Mo, you have this with your patients, but a lot of patients will come to me and say, hey, I don't want to change my diet, but what if I start taking a probiotic? Can that have the same effect of these diets? I don't know if you get that, Mo.
I definitely get that all the time, and I can speak about a half hour just about my thoughts on probiotics.
Yeah.
The short of it is I believe in probiotics, but I believe more in what are called prebiotics, or the nutrients that you find in good, healthy fruits and vegetables. I think what I tell my patients is if you have a little tin or one of those plastic tins of blueberries or blackberries, no matter how well you think you're cleaning those berries or that fresh head of broccoli or asparagus, you're not killing the bacteria in that. You're getting good bacteria. You're also getting good nutrients, which are the prebiotics that help the good bacteria in your gut. So yes, it's something that I definitely get a lot of. And I get a lot of patients that, again, very motivated, research the internet. And, I've learned a lot through my patients about diet and IBD. I had a patient that refused to go on biologic therapy. And for people that don't know what biologics are, these are medications that we use that are usually injectable or in an infusion type format to help suppress the immune system. And he followed a very strict ketogenic diet. And he had lost a significant amount of weight. And I will say, anecdotally, that he was able to keep his disease in a clinical remission state for quite some time. He did eventually get on the biologic, but there's definitely something to say about the diets. And I think it's very important for us to talk to our patients and allow them to have some kind of autonomy in their care. So they want probiotics, and they come from a community where they can afford to buy these supplements. Because again, these are not FDA regulated supplements. You don't really know what you're actually getting. But if they want to do it and they say that they feel better on these supplements or these, again, what we call complementary or alternative type medications, and some of these do have data behind them, right? So things like curcumin, which is a natural substance found in turmeric, for instance. There's great studies showing clinical remission in ulcerative colitis patients who take 2 to 3 grams of curcumin per day. So we do know that there are some good studies with that. And I try to keep my personal bias against it. And if it's working and they feel better, I tell them, please go ahead, do it, as long as you can afford it and it's not putting a financial burden on you. I think it's important for us to keep some autonomy for our patients and kind of guide them through this process. But yeah, probiotics for me are something that I have to bite my tongue sometimes and just kind of say, go ahead, it's great.
Yeah, we all do, I feel. I do something very similar. Patients come with a probiotic. I say, how long have you been on it? They're like, a week. Okay, how long does the bottle last for? 30 days. Okay, at the end of the 30 days, if you find that symptomatically you're feeling better, by all means, continue it if it's not a financial burden on you. But truthfully, these I got this probiotic from this store or that store. I don't know what's in it. I have no idea. I don't know how you think that I would know what's in it. We don't know. There's just too many probiotics, prebiotics out there on the market that as clinicians, no way we'll be able to keep up. But with regards to probiotics in the setting of pouchitis, like VSL number 3, we know that is effective treatment. And we can use that for that specific disease entity, meaning a patient that had ulcerative colitis, got their colon taken out, a pouch is created from their small intestine, and then it starts manifesting the ulcerative colitis as well, or disease process. And so we treat those patients with specifically a probiotic, VSL number 3.
Now, Dr. Case, if you could elaborate a little bit, because the VSL number 3 has always been a really wonderful thing, and in the studies, studies really look fantastic. Now, from what I know, that in the real life kind of open label type formats, that we really haven't been able to recreate any of the studies that showed that the VSL number 3 actually worked. In your practice with your pouchitis patients, and great way to describe who those patients are. Have you found it effective in your patients?
So patients in general don't want to take any medication that's going to suppress their immune system. Some patients have hesitancy taking antibiotics. So a lot of patients nowadays are looking for a very clean, holistic approach. So it doesn't hurt to start with VSL number 3. And yes, I will definitely see wins with the product with VSL number 3 in patients with pouchitis, but then there are patients that are resistant to it. So then we have to kind of go in a stepwise approach. Okay, what's next? Let's try antibiotics for a period of time. Keep VSL number 3 as some kind of some maintenance, and see if just by crossing it over with antibiotics can calm it down, that the VSL number 3 can continue to be effective. But as you know, sometimes some of the most difficult patients to treat are patients with pouchitis due to the recurrent flares and issues, and also those patients that have a form of ulcerative colitis that only affects the rectum and the sigmoid, which has been really difficult to treat.
Certainly.
Really difficult, and just those limited area. So that's kind of my approach with my patients. That's what I've seen in my clinical practice.
So if it's in the fridge, it's good.
It's in the fridge, it's good.
Right.
Yeah. Well, yeah, I mean, it sounds like, you both are, definitely doing what you can to help your patients, achieve their health goals. So we're going to take a quick break, Maximal Beings. So just hold 1 second and we'll be back shortly.
What's going on, Maximal Beings? It's Doc Mock here. Many of you are returning to the gym now, but some are not going back. Regardless of what you plan, Rogue has got the right gear to fit your needs. I personally own a barbell set and love it. The Black Ops shorts are sweat resistant and flexible for getting deep in your squats. Head on over to maximalbeing.com/rogue for our referral link. Order 3 items and they ship for free. And as usual, it's Doc Mock, and I'm here to maximize your pathway to wellness. If you're stuck at home and cannot make it to the grocery store, delivery may be the best way to stay clean and healthy. Instacart is the national leader in the direct-to-home delivery service. With numerous major chains and food from smaller stores, you can get those local veggies sent directly to your doorstep. Head on over to maximalbeing.com/Instacart and maximize your nutrition today.
Okay, and we're back, Maximal Beings. I'm again here, Doc Mock with Jackie P, Dr. Susan Case, and Dr. Mo Naem. A lot of the common things that we've talked about so far are about the input of macronutrition on people that have Crohn's and ulcerative colitis. And there are a lot of diets that have shown some evidence for these conditions, and a lot of common threads amongst those diets, but a lot of conflicting information as well. I think the biggest things being with fruits and vegetables, which are, in general, pretty good for gut health. But there are certain diets that restrict these from patients. I mean, red apples, that's like a butyrate producing bifidobacterium's dream. So I can't imagine ever wanting to restrict that in my patient. So I think Jackie has some questions for our experts here. Take it away, Jackie P.
I do. I feel like we should have some good answers here because of what you all do. So the first question is, we've spoken a lot about diet, right? And obviously diet is our fuel, which is important, but I'm going to take a sidestep and talk a little bit about physical exercise. Two-part question, and we can start with Dr. Case. First, how have you implemented some form of exercise and mobility regimen in treating your patients? And second part, what is your favorite exercise?
So with regards to that question, so you first of all need to know where your IBD patient is. Are they having a flare? Are they in remission? Are they transitioning to remission? So where are they in that process? So if a patient is having a flare, obviously that's not the ideal time to be trying to do any kind of exercise regimen other than staying active in a way that's not going to stress your body out too much. You're already fatigued, you're having urgency, frequency. It's not going to work. Just be cognizant about getting up, moving, not like laying in bed all day, really forcing yourself to get up and try to go for a walk outside if you can, if the weather permits. Here in the Midwest, absolutely not. It's too cold, but definitely try to stay moving. Now, for patients that are in remission, under control, there isn't one particular form of an exercise, whether it be a cardiovascular-based exercising or weight training. What I tell patients is, if you're going to start an exercise regime, you need to really listen to your body, because your body and your immune system doesn't know a good stress from a bad stress. So this motto, no pain, no gain, actually is not a good motto for patients with IBD, because if you push yourself to a point of no pain, no gain, and are not listening to your body, you actually can put yourself into a flare, because your body doesn't know a good stress. You're working out, that's good stress, right? It can't differentiate good stress from a bad stress. So you really need to know where to draw the line. I had a young lady with ulcerative colitis when I was a fellow in Chicago. And she's like, "Doc, I got this personal trainer. I'm going to lose weight. I'm going to get in shape." About 2 months into her training process, she came in with a major flare. I was like, "What are you doing?" She's like, "HIIT interval training." And I was like, "And how did you feel?" She's like, "At points I wanted to throw up." And my trainer said, "Keep going." I said, No. See, that's not going to work for you. When you feel that point that you're going to throw up, to that point, that's where you need to stop and say, "My body has had enough. This is where I draw the line." And believe it or not, she stepped away from doing that personal training with that trainer, kind of did her own thing, some light jogging, some weight training that she learned from her personal trainer. And 3 months later, disease under control, weight lost, and now knows how to incorporate different forms of exercise, but by listening to her body. So whatever you think is going to help you physically, mentally, emotionally, go for it. But listen to your body. Don't push your body past a certain extent that stress is going to become, can possibly trigger a flare. And we also have, there are marathon runners, believe it or not, who you'll see coming in for having an onset of diarrhea and blood. And you start asking them, "What's your background?" "Well, I'm a marathon runner. I just ran X marathon." Well, that kind of stress can potentially help the disease manifest itself. So you had the genetic predisposition for IBD, some environmental factors, possibly one of those being jogging, which you think is good for you, but you pushed it past the level that is then potentially signaling to your immune system, stress, and activated, and all the stars aligned, and here you are. Your ulcerative colitis or your Crohn's disease is now active.
Wow. So that's it's pretty tough. I mean, yeah, I mean, if you put your body under certain duress, I guess it will flare up other
Ex-
health effects.
Exactly. And I think that's the key. Once again, simplicity for patients is key. I don't need to impress them with big words and terminology that they don't understand. They want the real deal. They want it in layman's terms, and they want to be able to do what they want to do. They already feel restricted. I have this chronic condition. This sucks. Life sucks. No, it doesn't. And here's why. And I'm going to tell you why. You can do whatever you want. Like, obviously, if you're not having a flare and having urgency, frequency, but when you're in remission or on the process of getting there, just listen to your body. Don't stress it out. Baby steps, and you will continue to advance in your exercise regime, in your routines, and you will see success. But really listen to your body. That's all they need to know. And just by telling them that little pearl of insight, which they didn't really think about, that stress could potentially be negative stress, even though it's coming in the form of exercise, it can be really life-changing and really change your trajectory.
Oh, that's good insight. Thanks for sharing that. And the second part of that question, what is your favorite exercise, Dr. Case?
For myself or for my
Yes,
patients?
for yourself. What are you doing
for myself?
to break a sweat?
Okay. So before COVID era, I used to really enjoy a combination of weights and cardiovascular through something called Orange Theory. I'm sure a lot of people have heard of it. But since I can't really participate in that presently due to COVID, switched over to just doing my own in-home regimen, if you will. This program that incorporates body combat, which is kind of cardiovascular, with some body pump, meaning weights, and then some spinning, cycling, to just keep it variation so I don't get bored. I don't know if Mo's doing something different.
Well, I learned a lot from this discussion on exercise. That was really awesome. So I always learn something new from you. I don't do anything differently at all. And I agree with you. I've actually tried to work out before with Dr. Mock, and he tries to push you to the extent of throwing up. So I stopped working out with him because he's intense.
Jackie
literally.
P knows that too.
That's true. Yeah, when you said blood and diarrhea, I'm like, yeah, that sounds like a workout session with Doc Mock. That's not good? Oh.
Yeah, that's not good. It's actually
That is definitely not good.
Yeah, that's too intense. That's definitely intense. Schaefer's like, that's a normal weekend for me. That's my high interval weekend training right there.
Yep. 90 burpees today.
Once he starts throwing the ball on the wall, I'm done. Exercise is personally for me an integral part of my life. I try to do at least 3 to 5 days a week. As I'm getting older right now, and I'm not that old, but I definitely still feel it. I try to do more low intensity type stuff, but I still do some high intensity cardio. During the summer months, you'll see me outside on the trail doing 50, 60 miles on my bike. When it's a little colder, I may be on my spin bike or running outside, doing something at a moderate pace, 5, 6 miles when I do go running. And I do like weightlifting as well, but again, low intensity weightlifting. I'm not trying to win any bodybuilding contests.
Come on, Mr. Wonderful. Come on.
Yeah,
You your name written all over it, Mo.
I can't. Not anymore. It hurts. It hurts. I definitely feel it. Now, Dr. Mock, when you see him at the gym, he definitely inspires you.
Well, thank you, friends.
If you see Doc Mock's calf muscles, you have to be
they're incredible.
How many miles are you running to get those calf muscles?
It's genetic. That is genetic.
Yeah. Thanks, Dad. Yeah. If you're listening out there, I think you guys also brought up a really important point, and we see this time and time again. Not only in my clinical practice, but also with our clients, is that people get placed on all these kind of bro science-y plans, right? Their trainers train them a certain way, which that's their area of expertise, but then also put them on a super restrictive, very odd diet plan. And it's just a disaster for people that don't fully understand the disease state, like inflammatory bowel disease. So, It's our job as healthcare providers to educate them. It's their job to educate us and continue the conversation rolling. We work as a team together, and you need to know what you're recommending to people. You need to know the science.
Absolutely.
And you have to do it with a certain sense of tact, right? Because I know one thing is that a lot of our patients, that they do have personal trainers. That's a really close relationship. I mean, they've built a bond with that person. And as a doctor, for you to say that what they're teaching you is wrong, it's just not the right approach. So it's about some tact. It's about kind of listening to what they're saying and kind of slowly, kind of teaching them along the way about what's good, what's bad. 'Cause I think one thing I've learned in my practice now, and I've been for about 12 years now, is that you have to listen to the person in front of you talking. You can't just denounce something or speak poorly or negatively about whatever that they're talking about, and slowly kind of have them gain your trust. So yeah, a lot of these bro diets, it can be very frustrating, and I bite my tongue as we're having the conversation. But I allow them to kind of teach me about it, and sometimes I have to go research it myself and go from there.
Yeah, and to echo that, actually, perfect segue, Dr. Naem. It is good to have a team around you, right? Dr. Case, you said that you refer folks to a nutrition, right? And so everyone's having that conversation, and maybe there might be a thing where your personal trainer should have a conversation with your doctor or in your care team. But on that note, I've got another question for you both. And Dr. Naem, this one's going for you first. Speaking of diet and nutrition, what is the craziest diet you have heard of or potentially tried back in your non-doctor years?
Oh, I have. Oh my gosh.
Well, I think we all know that the South Beach diet. I think it was the really kind of started the whole thought about diets. I think obviously we've shown that's not a good diet, and they've had like a modified South Beach diet. I honestly think the craziest diet is the ketogenic diet. I think that's the intermittent fasting. Although it's extremely effective, I know a lot of people that have done it, and it works wonders. But I think it's a very restrictive diet, and it doesn't seem to me that it's a sustainable long-term diet. Now, some people who are programmed that way can do it and stay on it. And I think Dr. Mock I think you were on a intermittent fasting keto diet, correct?
I don't do keto per se, but I fast pretty much every day. Humans have been doing it for thousands of years, and it's very easy.
It is very easy.
Not for everybody.
For some, but not for many.
If you could do it, I think that is a great way to diet and to kind of get your body into a certain way of breaking down the fats and nutrients. But I think for me, it's more about moderation, something that's more long-term, that's more sustainable. I had a patient that was on a strictly chicken broth diet. That's all she did. And she also was able to maintain some form of remission in her disease. And I just said, I don't understand it. I can't explain it. It works. So I'm very happy for you. But I think the worst one was the South Beach diet, which was really high in red meat and animal fats, and which again, we've shown that animal fats probably aren't as bad as we think they are. But diet rich or high in red meats is definitely probably not the way for us to go. So that's probably the craziest diet, and I'm glad that we've kind of gone away from that diet. And the future really is going to tell us which diet's the best. We just need some more time to really know which diet we all should be following.
I've tried a lot of diets in my days. I will say two of my most outlandish diets that I tried on myself back in college at the University of Michigan. I wanted to lose weight fast. So I decided to do the Slim Fast diet, very popular. A shake for breakfast, me chugging a shake on my way to morning lecture, a shake for lunch, and then a sensible lean cuisine microwavable meal. Terrible. Then fast forward, I'm in my GI fellowship in California, just new place, new set of clinical responsibilities, just trying to figure out where I fit. How do I be a good GI fellow? I subsequently gained 15 pounds in the process. Not good. So I said, well, I really want to lose this weight fast. So at the time, there was a big, crazy, Dr. Oz was pushing Hcg diet. So it was a very caloric restrictive diet. And then you would have to inject yourself with Hcg. And then in the morning, test your urine.
Naturally.
And yeah, I mean, listen, the caloric intake was so restrictive, like 800 calories. Of course you're going to lose weight. Why am I injecting myself with HCG? Like that was an epic fail. It was awful.
Did you actually inject?
I did. I actually did inject.
Where do you get that? Where do you get the
It was through a company. It was through a company through Canada.
Oh, through Canada. Very reliable.
Yeah.
Very reliable. See, hey, let people know, even though we're clinicians, we're human too.
Yeah.
Hey,
Sure.
we try things. We're just like everyone else out there in public. If there's a quick fix, we want it too. Sure, of course. So those are my two most outlandish diets that I've done. Since then, I have moved away from that, and I will let you know that I personally, for my dietary habits now, with all the information, the knowledge, and the research, I follow a more specific carbohydrate diet and an anti-inflammatory diet, if you will. That's kind of what I do. It's not restrictive, and it's not truly restrictive. It's just making better choices.
Nice.
The truth is, for me, I follow a really awful diet. I eat a lot of, I eat way too much red meat, maybe a little too much wine that's recommended on the Mediterranean diet list. But thankfully, exercise goes a long way.
That's good. No, Dr. Oz, I think we both, Dr. Oz and I went to the same med school, I believe,
really?
if I check the facts, which was no med school.
I think,
yeah.
I think you guys brought up a lot of important points here with diets. It's that every person is different, right? Depending on your background, your genetics, the way that your genes are, the proteins that your body is made up of are expressed in those genes. Keto is not for every person, right? People have PPAR gamma gene mutations. They oxidize fats. So fats are bad for those people. It's not as straightforward as you think. And so that's why, again, it comes down to understanding the science, practicing things methodically, and figuring out what's best for that individual person. Back to you.
I think it's important to mention that with diets, what is your goal? Is your goal weight loss? Is your goal building muscle? Is your goal looking for a more clean anti-inflammatory? What is your ultimate goal? So based on what your goal, there are different recipes, different diets, and you can try for a period of time to see if it's successful. It's all trial and error.
That's a good point. That reminds me of R.N. Graham, who's not on the show here, but I followed one of his diets once upon a time 2 years ago, and I believe Doc Mock did, and we had two completely different reactions. I got lean. I was pissed off all the time because it was a carb cycling diet, right? So like everyone knew at the office that don't mess with Jackie on Tuesdays because those are no carb days. So I was just short with everyone. And Doc Mock had a completely different reaction. So
did not work at all. No.
Yeah.
No results.
Yeah. So, it comes down to, sticking to something long enough to be consistent to make sure it works for you. But if it doesn't work for you, right, you two doctors, right, who are, probably the smartest people around than the average layperson, right? You had your trial and error. So regular folks out there, right, it's okay to just, stumble here and there when it comes to your nutrition goals in your journey. Last question. Mm-hmm. Favorite health book? And Dr. Case, you can go first. It looks like you have it.
I have them. Ready to go. So first and foremost, my favorite book personally is Breaking the Vicious Cycle. This talks about the specific carbohydrate diet. And when my patients are really ready and really committed to wanting to change their diet and hopefully feel better, as well as decrease inflammation and potentially even come off some of their therapy, I say go to Amazon, get this, read it, come back, let's talk and go from there. Then the second is great book, The Mind-Gut Connection, which I know we're not talking about, but also a very phenomenal book. So two
Really good
different
book.
ends of the spectrum, diet, mind, gut, they both play a role. And that's not something we're talking about today, but maybe for next time.
Stay tuned, folks. Dr. Naem?
I don't have books prepared, so I wasn't ready
Shame on you.
for that question. But I'll have to just go on what Dr. K said. Those two books look fantastic.
Don't worry.
I'm reading them today. I
All right,
promise.
perfect.
They're ordered on Amazon already in my inbox, in my cart.
Amazon Prime, right?
Yeah. Knowing Amazon Prime is probably already on your doorstep right now.
Yes.
So this has been an amazing conversation. I think we're running short on time. I'd like to personally thank my co-host, Jackie P, for being there time in and time out. And thank you so much for Dr. Susan Case and Dr. Mo Naem for sharing their thoughts. For all of those out there that have inflammatory bowel disease, feel free to reach out to us at maximalbeing.com. You can send us an email at team@maximalbeing. We're happy to discuss more of a holistic sort of approach to your gut health. Dr. Case, you have a really educational Instagram page. Where can people find you on social media?
Yeah, you can definitely find me on @Dr. Susan Case on Instagram. My Instagram platform is really to educate, talk about topics that really matter from a real GI doctor that has the background, the interest, and able to take complex medical information and give it back to the public in a way that they can understand, make sense, and hopefully implement some of the pearls of insight that I'm providing for them. So I really appreciate you taking the time to have myself and Mo on your podcast today. I think talking about the subject matter is very, very important. Hearing about it from two board certified GI physicians is very important. And also letting the IBD population know that we are talking about this. We are trying to help them. We are trying to give them evidence-based recommendations when it comes to their diet. And then for my wardrobe change here, it's all about making IBD visible. So thank you so much.
Nice. Dr. Naem, what's going on in your world these days?
I'm learning from Dr. Susan Case's social media school on how to put myself out there and be more marketable. It's something that's still kind of new for me. But our office, we're at North Shore Gastroenterology. You can find us on Instagram, Twitter, Facebook. And it's a group effort with myself and my partners at the office. And we also put a lot of content on there for the community with links and stuff to certain studies, diagrams, information just in terms of general GI or gastrointestinal disorders, including inflammatory bowel disease. That's a great way if you want to look us up at North Shore Gastroenterology. Again, we're on Facebook, Instagram, Twitter. I think I might be forgetting one of the other platforms, but you can find us on there.
All right, thank you all so much. And for those of you Maximal Beings out there, stay tuned to more information from these wonderful minds out there. And as always, I am Doc Mock here with Jackie P, Dr. Mo Naem, and Dr. Susan Case, and we are here to maximize your pathway to wellness.
What's going on, Maximal Beings? Doc Mock here. If you haven't done so already, leave us a comment and hit the subscribe button. Let your friends and family know. That way we can get the word out and continue to bash the bro science.